Welcome to Decoding CTO, case 47. I'm Dr. A. Sharath Reddy, consultant cardiologist, Medicore Hospitals, Hyderabad. So today's case is a facilitated ADR in a Post-CABG RCA CTO. So this patient is 63-year-old male with exertional angina, had bypass in 2009 with Lima to LAD and SVG to right coronary artery. Recent graft angio showed native calcified triple vessel disease and patent Lima to LAD, occluded SVG to OM as well as SVG to RCA with a significant lesion in LCX and CTO in right coronary artery. So earlier attempted LCX stenting in other center, but was not able to finish, and patient had moderate to severe LV systolic dysfunction. So this was the anatomy. You can see this is SVG to RCA, so which is totally occluded, and we can see this is a native right coronary artery, which is significantly diseased from origin, and mid is totally occluded, and we can also see distal RCA is filling from a collateral, from posterior atrial branch or sinoatrial branch. So this is a native RCA, which already I explained. You can see there is an ambiguous cap here with total occlusion, and this is a collateral which is filling distal RCA. And Lima to LAD showed clear filling of right coronary artery, and you can see this is a flow into the right coronary artery. We can also witness a couple of RV branches filling from RCA, but what is prominent here is it's a very narrow thin vessel and looks diffusely diseased. So overall visibility is not that great, not that conducive for antegrade wiring in this case. And LAD a calcified and significant lesion and with a mid total occlusion, but in fact Lima to LAD was patent, so which was filling his distal LAD. So during angiogram, detailed scrutiny was not done to visualize septal collaterals filling right coronary artery. So we can see good septals, but we are not sure about their connection to PDA. They might be connected, but we are not sure about it. And this is a Lima. You can clearly see Lima to LAD is quite good. I think this is the only vessel on which his entire LV is dependent, and is surviving on this vessel. And we can clearly see it is filling RV branches as well as partly PDA is being filled from this Lima to LAD. So looking at JCTO score, so this is CTO with an ambiguous cap. You can see clearly cap is ambiguous, and length of the lesion is definitely longer. In antegrade injections, it looked very long, but when we took a Lima injection, you can see RCA is filling up to this point. So probably appears as a shorter CTO, but only counterpoint is this vessel is diffusely diseased, which makes us more difficult for even antegrade wiring, and almost it behaves as if it is a long lesion. So coming to calcium, so it is significantly calcified lesion. So overall JCTO is like 2 to 3. And regarding wiring strategy, so for this patient with a very poor visibility of distal RCA, so to make this RCA visible for antegrade wiring, I think we need to have a triple injection. But despite triple injection, I'm not quite comfortable about the distal vessel visibility in this case. So that was a challenge for antegrade wiring. So that's the reason I decided to go ahead with primary retrograde wiring in this case. So what channel is good for primary retrograde, especially when patient has significant LV dysfunction, and when we are doing case without mechanical circulatory support. Of course, if patient is affordable for mechanical circulatory support, this is a good scenario, but as he was not, we had to plan without mechanical circulatory support. So in that scenario, which collateral is good? Is it a septal collateral or SVG2 RCA? So since SVG2 RCA is already occluded, so this may not create any ischemia. So that's a fundamental reason why we prefer to go with SVG2 RCA in this case, not septal collaterals, because these are big septals, and in a patient with severe LV dysfunction, in the process of retrograde, I might create an ischemia, which can create a problem in this severe LV dysfunction. So my choice was SVG2 RCA, and of course the challenges is crossing SVG2 RCA. That's one challenge, and second challenge is what after crossing SVG2 RCA. So how to turn the wire back into distal RCA. This is going to be another challenging thing. So coming to procedure, so we took a dual angiography with antegrade injection through the microcatheter, but we realized RCA got occluded completely up to the proximal RCA. Before it was visible up to mid RCA, now it is totally blocked. So it's, but again it's a ambiguous cap, so no cap visible here. So essentially we decided to go ahead with primary retrograde. So this is primary retrograde, so with the Corsair 150 with it's a pilot wire, I think most pilot 200 or Gladius, I think Gladius wire. So Gladius MG, which can be even knuckled subsequently. So Gladius MG, we could enter SVG, and then followed by Corsair 150, and then so we started knuckling from this point. Same Gladius we knuckled, and subsequently we crossed the entire SVG with the knuckle. So you can see the knuckle is being advanced. It is traveling knuckle, and we further advanced microcatheter into distal RCA, and then we checked, and we can see now we are in the distal RCA, and we entered into RCA even before cracks, and all the vessels were visible here. So what are the next options once we reached distal RCA? So one option is now I have to start antegrade wiring, and if antegrade wire is subintimal, and most likely in that's what happens in this case, because it's a very long CTO. In fact, now it is up to ostial RCA occlusion, so we might end up in subintimal technique here. So you bring your wire up to distal RCA antegrade. If it comes subintimal, then go with the facilitated ADR. So bring a balloon on this SVG wire, SVG graft wire, and then try and re-enter with antegrade wire into the distal true lumen. So this is facilitated ADR, and the other option would be like turning your retrograde wire through SVG into the mid RCA, and then come with antegrade wire and then do reverse cart here. So these are the two options, but technically this is going to be challenging. We can try a reverse wire technique to enter RCA, mid RCA, but often it may not work because the vessel is diffusely diseased. So I tried reverse wire technique to wire RCA, but failed miserably. So that's when we decided to go ahead with antegrade wiring, and probably most likely facilitated ADR. So started wiring integratedly. So took a Corsair along with Gaia 2. So advanced Gaia 2, making seeing the wire in two orthogonal views to understand whether the wire is within the vessel architecture, as the course is completely ambiguous here, as the vessel was not visible. So as the wire was stuck here, so we tried on dilating to advance the microcatheter, and after balloon dilatation, we advanced microcatheter further down. But then that's when we realized we switched our wire back to Gladius, and we realized the wire movement was not so conducive, and not really convinced about its location within the vessel architecture. So we wanted to confirm whether the wire is within the vessel architecture, or just give an injection to see where the vessel architecture is. So we injected, and that's when we realized the earlier wire course was not appropriate, and you can see so the course was actually quite posterior in RAO view. So with that we decided, so we go ahead with knuckle wire. See, we can't really direct wire here, so again took filter XTR and knuckled filter XTR. Now you can see earlier wire was here, now the wire was going here. This was the vessel architecture, and we confirmed knuckle travel in two views, and made sure the movement of knuckle is appearing as if it is in the vessel architecture. We can see, and we advanced Corsair along the knuckle, and yeah, now we can see knuckle reached distal RCA, and it is sitting just beside the distal RCA, which we injected through the W-lumen catheter, which was kept on retrograde Y. And this is one we have to switch to facilitated ADR. And what we have to make sure here is your wire entry is quite proximal to crux, so that you don't lose any side branches of RCA at the crux. And yeah, so we took a 2.5 balloon from SVG, and we dilated in distal RCA before crux, and then took a directable antegrade wire, that is Gaia 2, through the antegrade microcatheter, that is Corsair, and directed it towards the balloon in two orthogonal views. And we did kind of end balloon and side balloon technique, and we could enter RCA, and subsequently we exchanged wire to workhorse wire. And that's we did an IVUS, so to confirm the entry point is proximal to crux. That is the crux of this technique. So you can see here, this is PL, and which is joining the true lumen, and the lumen in which IVUS catheter is, and another side branch also was there, which you can see here, that also joined true lumen. So we are true lumen even before crux, and once we come proximally, and then you will realize we slowly get into false lumen at one point, so which I'll show you in subsequent slides. You can see here, now we are in false lumen, and true lumen is now compressed at 12 o'clock, and you can see the wire which is coming from SVG, which is there in the true lumen, and this is all true lumen compressed, and slowly this wire gets into SVG, and which moves away from this vessel. So understanding this is very important before you get into further steps. And you can see this is where your PL joined, and this is a confluence. We are in true lumen. This is another branch joining true lumen, and then we get into false lumen. So this is a schematic diagram to understand the important points which you have to look at One is PLB origin in IVUS, next is this branch origin IVUS, and subsequently this is how it will be. So this is the subintimal space which was created by antegrade Y, and this SVG. So all this portion is in subintimal, this is true lumen which is compressed, and this is the subintimal space which got enhanced. So when you see IVUS, you will have true lumen compressed with a wire which is coming from SVG. So that's what happens. You can see here. So distally we are in true lumen, and now we are coming close to this subintimal space. You can see already wire is in subintima. These are the cuts here, and now this is intimal space which is compressed, and the antegrade IVUS is in subintimal space, and now you can see this wire in SVG is moving away, and now this is venous graft completely gone out of your vessel architecture, and we are clearly subintimal, and this is the true lumen which is compressed. So once we are sure that it is entry point is quite proximal to crux, we can go ahead and dilate and do stunting. So we stunted entire length of RCA, and followed by, this is a final result. You can see entire distal RCA is filling and all the branches are intact, and two acute marginals, since we are subintimal, were lost antegrade flow, but anyway those two marginals were well filled from LAD, so that's okay in this case. So we can see here there is a little bit of under expansion since it is completely subintimal, so optimal is suboptimal in subintimal course. So to conclude, facilitated ADR is a good alternative in suitable cases of post-CABG RCA CTO. It can be used in other suitable anatomies where you have an antegrade wire in subintima, and you are able to deliver a retrograde balloon into true lumen, something like original cart. So ensure re-entry proximal to crux when you are in RCA, and confirm your entry before IVUS with IVUS before proceeding further. Optimization of stunt expansion in long subintimal space is important. Accept the suboptimal, don't try too much in the same sitting, mainly to avoid perforations. Thank you, and you can subscribe to this channel for more such videos on CTO and complex PCA.